Hi, everyone. I'm Dr. Rebbecca Hertel. I am a board certified osteopathic physician and menopause specialist. And I am here with Aaron Hertel. He is a physical therapist, owner of his own business, has been in the physical therapy world for over 20 years. We are going to talk about this awesome little article that just came out by Dr. Von der Wright, the Musculoskeletal Syndrome of Menopause. I'm going to let you introduce yourself. And you actually um, used to work with her or had referred patients to Dr. Von der Wright when she was in Pittsburgh. Is that right?
Yeah, that's right. That's why this article was so exciting to me to read. But I'll just start by introducing myself. Thanks, Rebecca. My name is Aaron Hertel. I'm a physical therapist. I've been a PT for over 20 years now, which surprises me that went so quick. It doesn't seem like it's been that long, but 20 years goes by fast when you enjoy your job and what you do and helping people. So we got to know of Dr. Von der Wright when we found out that she was, in our minds, the best orthopedic surgeon when it came time for diagnosis and treatment of the hip. Dr. Von der Wright, her specialty was arthroscopic hip surgery for men and women, which now looking back, it was predominantly women who we would find who had hip problems, and we would do some diagnostic tools. And a lot of times we found out they had internal derangement of the hip, particularly their acetabular labrum. If we found an impingement in that area, or better known as cam impingement, or sometimes even a tear of the acetabular labrum, we would refer them down to Pittsburgh, Pennsylvania, where they'd be evaluated by Dr. Von der Wright. And she's magnificent in determining if these clients needed surgery or conservative medicine or a combination of both. So that's my history. That was
Oh,
probably 15 years ago.
yeah, I was going to say, how long ago was that?
I
Because
I can't,
she's not in
Doctor.
Pittsburgh anymore. So.
Yeah, Dr. Wright would be able to put a number on it, but I would think it's 10 to 15 years ago, more like 15 years ago, that we would be referring her patients down there. And like I said, most of them are younger patients, female, and that we would send down there because they were not appropriate for a total hip replacement. So it wasn't osteoarthritis. Their X-rays would be negative. It'd always be an internal derangement that would come up on MRI, and typically the acetabular labrum in the hip. And that's the only place that we would send them, because in Erie, no one was doing at the time, and even now, there's not many people that do the arthroscopic low invasive hip surgery.
Okay. All right. So that's awesome. You've got like a little bit of history there. And I'm sure, as everybody else has probably realized here, we don't have the same last names for nothing. This is also my husband. We've been married for over 10 years, and he's watched me come into this whole menopause space. And we have now had so many just really awesome conversations about, women with frozen shoulder and other musculoskeletal issues that you've brought to me and was like, I didn't know why. And now I know why. I've listened to, he and my boys, and probably all of my kids have listened to all of my lectures that I've tortured all of them with for the last few years. And so we've kind of come into this space like really bouncing off each other now. You know, the women that you're seeing or that you have seen in the past that you just really didn't know what was going on with them. What were some of those more common dysfunctions that you would see women for in their midlife that you were just like, listen, no trauma, nothing happened. Why am I seeing this? Why am I seeing so much of this?
The most obvious one is frozen shoulder. And as you all know, anybody who follows Dr. Wright knows that she speaks about frozen shoulder all the time, because that's what she sees when she, is working as in her orthopedic surgeon space, is frozen shoulders. So just to give you a little background on frozen shoulder, it training and schooling and anything you read online, it's idiopathic frozen shoulder, which means we don't know why it it happens, and it's typically in women in their 40s, 50s, and 60s that would come in, no major injury, no trauma, no, they didn't know why. All of a sudden, they just can't reach their bra strap. They can't reach behind their back. They can't scratch their back. They can't put their belt on. Things like that. And they would be debilitated. That's why frozen shoulder comes up so commonplace, is because it's very debilitating. If you can't use your arm to put your belt on or scratch your back, or for a woman to put her buckle or bra strap in the back, that's debilitating, and that affects function. So we would see a lot of, the only course of treatment for the most part is physical therapy, other than a manipulation. But who wants to get put under and get their arm, forcefully manipulated by an orthopedic surgeon? So typically it would be weeks, more like months of physical therapy. And there is 3 phases to it: pain, freeze, and thaw. So each phase lasting up to 2 months. So we're talking 6 months of debilitated frozen shoulder. And we just figured that they didn't have a reason for it. They didn't have a cause. It was just, we treated this for years, 15, well, actually, until you took your menopause certification, did the keywords start coming up: frozen shoulder connected with perimenopause and menopause symptoms and the decrease in estrogen. I even start thinking about it. So I did treat it for 20 years, not knowing why this was happening to women. Then, since we saw that in those findings, the link between frozen shoulder and menopause, perimenopause symptoms, I said, why don't we look at everything else? Anything else in a woman, female patient that I see between, let's just say, the ages of 40 and 60 years old. Okay. Let's look to see if there's a factor. It could be related to perimenopause or menopause symptoms. And it seems like one after another, we're finding these relationships. It's crazy. Plantar fasciitis, knee pain, early onset arthritis in knees. We talked about frozen shoulder, back pain, elbows, lateral epicondylitis. I even saw a female client who had a Dupuytren's contracture of her hand. That is when your finger just gets stuck and you cannot extend your finger. The tendons get stuck in your hand. And I told her, of course, this is after all our discussions, me, luckily enough, being married to you for many reasons, but in this case, getting to watch you go through this menopause training and hearing all your trainings. I talked to this client and discussed the possibility of these symptoms being from decrease in estrogen and her being in the menopause stage of her life. And she adamantly refused that this is why her symptoms were from. And so I go home, and the two of us, Rebbecca and I, researched it. And sure enough, doesn't AI come up with a relationship putting Dupuytren's contracture with symptoms of perimenopause and menopause, particularly the decrease in estrogen. So now I think we have to just look at any non-traumatic musculoskeletal injury.
Right. Insidious onset, right? Mm-hmm. They're coming in, they don't understand why. Right.
Right. Exactly. We have to the light bulb has to go off. If it's a female, I don't want to put these patients in like their own category, but you have to have the conversation.
Well, especially now, with this whole article coming out as well, right? So in physical therapy school and your PT training, did you get any midlife or hormone therapy or any training? Because I didn't in residency or my medical training. So physical therapists, do you guys get any of that training at all with women in midlife and these types of musculoskeletal symptoms?
The short answer is no, we did not.
Mm-hmm. Right.
I'm not even sure it got brought up.
Right.
That was the thing.
Right. And then I don't know how easy it is to tell me, the percentage of these patients, clients, whatever that you may see that are midlife that happens to, non-traumatic. If not, it might be a good little study to start.
That would be a fan. Yeah. I've thought about it to now that this paper that Dr. Wright put out there is on the table. It would be great to find out, what percentage of these women have we been treating as healthcare professionals for me 20 years plus, that were this whole time because of drop in estrogen in their body and
Mhm.
menopause symptoms.
Right, exactly. Not to mention just, and there's so much more in here with, fall preventions because of osteoporosis and, you know, the keeping your muscle memory so that you're limber and so that you also don't fall, so that you prevent sarcopenia. This is, I assume, even it's so important, definitely for my space of healthcare, but certainly for your space of healthcare. When you read this, were you just like, what other things in here were A, sent light bulbs off, or B, like, is this going to change the way that you're practicing? Or, maybe you were already aware of some of this, but becoming just more um adamant, in educating your clients.
I can tell you right now, Rebecca, that I am only aware of this because I'm married to you, period. Unless someone is doing some out of the box research or some continuing education that is linked to menopause and perimenopause, I can speak for my profession that um, physical therapists just are not educated on this stuff. And I haven't seen a
And
con ed
not to
course
their
come through.
fault, right? Not to their
No,
fault. Although the space is getting so big, I think, like Dr. Wright was saying, and like all of us who spoke about this paper, we said you need to print this paper out and take it to, your physical therapist, your PCP, your orthopedist.
right.
I mean, now this is a medical literature. The fact also that it was put put out so that anyone can print this out, is big too, because they had to pay for that, to be open for anybody to print it, which is pretty neat too.
Right. I have it. I have it right here. And my screen is blurred, but I have it highlighted and I'm going to have it at my clinic. And number one change for me is going to be just to have the conversation. If you're a female, 40 to 60, and you have a non-traumatic injury or pain, I shouldn't even say injury because non-traumatic, or if you have a pain or a functional problem, um, that is idiopathic, meaning we don't know why, there's no mechanism of injury, I'm going to have that conversation right off the bat that this could be related to menopause or perimenopause symptoms. And we need to have a conversation, or they need to have a conversation with a certified or trained menopause practitioner.
Right. Yeah. And so the neat thing is that there are, some of the professionals in the menopause space that are going to start training or have courses out for allied health professionals. So, physical therapists and PAs and nurse and, psychiatrists and therapists and any provider, um, that would like to know more about that. So that way they have the education and knowledge in order to take care of patients, appropriately and be educated, because it wasn't in any of our general training, right?
You're right. And I actually love my job all over again. When you learn something new, it's actually it's exciting to go in and be able to talk to these women and be like, hey, guess what? And I'm a male, and here I am talking to you about your menopause and perimenopausal symptoms. At first, I thought they were going to kind of like take it the wrong way or possibly get offended or be like, you're a guy, why are you talking to me about this? But they love it. They love that, their therapist is in tune. Doesn't matter if I'm a male or female. And of course, I go right to, my amazing wife and how she has all this training and how I kind of learned this with her, and she's teaching me as I go, and they just love it. And I just urge them all to have the conversation with a trained healthcare professional in this menopause space.
Yeah, awesome. So what were some of your favorite things that you want to talk about with this article? Things that you were just like, oh my gosh. I mean, I think the whole thing's fantastic. Um, I definitely liked how it was, broken down, and you probably even see this, just the sarcopenia in general when you're trying to just rehabilitate patients who have had surgery, right? I mean, you have to take that into account too, that if, how much of their muscle, if they've been on bed rest or had to be on bed rest, and now we're just thinking about just maybe women coming to you in general who have either are trying to recover from a surgery and getting therapy, or just some that are, just trying to get stronger, right? You do things, you also are doing things to help clients have better longevity and be strong. And so you're not just doing a physical therapy portion of that. You're also doing other things in this space, right? Why don't you tell us a little bit about that?
Absolutely. If you don't mind, I'd like to back up just a second and go back to the article, the big points that hit me. 70% of women in that perimenopause, menopause stage of their life are going to have symptoms, musculoskeletal symptoms of menopause. That's huge. 70%. So
Huge.
that's okay.
I
Obviously,
did.
yeah, that's the majority. So
Yeah.
right away, knowledge, you got to have the conversation that this is a thing. It's on the table. If you don't have a mechanism of injury, there's a 70% chance that this is from menopause, okay, or related to that. Okay, that's one. Number two, I want to talk about the big four. To me, the big four. Inflammation. These are the symptoms, the musculoskeletal symptoms of menopause. Okay, inflammation. Okay, we all know inflammation, joint inflammation. Okay, that's the pain in your frozen shoulder, your knee pain. Sarcopenia, as you just hit on, that's muscle loss, muscle weakness, muscle loss. Osteoporosis, that's bone loss and more frail bones. They fracture much easier. And then arthritis. I mean, that's my job right there in a nutshell, those big four. That's what I treat, those four things. You can almost break any of my diagnoses that I treat on a daily basis into one of those four. So the 70% of women, those are the four symptoms. And then with that, I've come up with four things that I'm going to do differently with these patients. I can talk about that now or let you.
Yeah, no, I want to hear.
Want to hear
Yeah,
about it now?
yep. I think
Okay,
that's really awesome. The fact that you're like, oh my gosh, I'm almost like changing my whole way I'm treating these women, or, treating my clients based on, like, reading this article. And I
yeah,
mean, that's pretty neat stuff, I
absolutely.
think.
Like I said, I'm excited about it just like you are, because I have a whole new way of treating. 75% of my practice are females. And then of the percentage of those females in the menopause state of their life is very high. So this is huge for me and for all the people that I try to help and all the people I try to take care of. And I like to break it down, make it really simple. In my brain, if it's not simple, I don't understand it. So we had the big four, the symptoms. Now I'm going to go the big four things that I'm going to do differently, and hopefully other physical therapists and occupational therapists and chiropractors and doctors will do the same. I'm going to counsel them one on supplements to make sure that they are taking their vitamin D, vitamin K2, supplemental protein as well. We'll talk. Number two is going to be nutrition, supplemental protein and creatine. That's my big four. So supplements is going to be number one. Make sure they're getting all the supplements that they need for bone health, for muscle health, for strength. Number two, nutrition, making sure that women in this stage of their life are getting enough protein. And I'll let you talk
They
about
hate protein in midlife.
Yes.
I know. I counsel all the time about this, like ad nauseum about this, because we just, Gen X and older, we were just like, no, the protein was just not a thing. And so, those of us that are now more into lifting and resistance training, we understand the importance of that, but I counsel all the time about it because they just don't want to hear it.
You're
So
the
we
you're
have to
the
like change the narrative.
Yep, and I love to see that everybody, there's a huge push on social media on strength training, and strong is the new in, and I love it. But still, you got to remember that's the 5%, maybe 10%, 90% of the clients I see, and I think 90% of the country is on the other side of it. Like when you tell them 1 gram per desired lean body mass, we're
Their
talking
eyeballs are like,
120 to 150 grams of protein a day. The eyeballs go like this. No way can I
mm-hmm,
get that in. I hear it all the time.
mm-hmm.
So that would be number two is protein. So supplements, number one. Number two is nutrition. Make sure they're getting the adequate amount of protein.
Right, fiber and
Yep,
protein and
you got it.
hydration. Yeah.
Number three, conversation treatment piece for me is resistance training. And instead of concentrating and focusing on modalities to decrease inflammation and range of motion type things, those are important. But as soon as we can, once we get the inflammation down, the pain down, we're going to resistance training way quicker than we ever were, especially with these women who are, let's go into the later stages of menopause, the 50, 50s, 60s, 70s and beyond. We're doing resistance training. I have 94-year-old women in the gym doing strength training because they can't stand up from if they're gardening and on all
Right,
fours or on their knees to try to stand up, they get stuck in their gardens. They can't get up, and that's because strength loss.
right,
So
right. Or they fall, right? Or
that's
they need
correct.
to bring in a bag of groceries up like a step or two.
Correct. Laundry,
Mm-hmm,
groceries, all
mm-hmm,
that stuff. So resistance training is huge. And then point number four that I brought to my practice to help these women in this stage of their life is that conversation and referral to a menopause specialist, whether that be their family doctor if they've had menopause training, or their OBGYN, um, anybody in that state. And I think you can speak to that better. There's just not a whole lot. Luckily enough, I know you, so I can always direct them to you or have you help me find someone that they could go to. But
mm-hmm.
I don't think for other people in um, my profession and my workspace, it's hard for them to find someone who's menopause certified,
Trained. Yeah,
menopause trained.
trained. Who's not going to
Right.
take advantage of them. And yeah, I think the probably newer statistic now is maybe like 2,000 providers for every 32,000 women. It just isn't enough. I know it.
Right. Right. So I
But
got
we
lucky.
can't give up. We just gotta keep educating, and we're gotta try and infiltrate into those educational systems and schooling and things like that, and do what we
Right.
can, as providers to educate these students. So
Right. And I think what you're doing is amazing. You're educating not only other providers, but that you're educating that 90% of the population who just doesn't know, where to go. They don't know they don't know what to eat. They don't know how to strength train. And then all those women who are in that stage of their life have these symptoms and they don't even know they're having them or why they're having them. So I think the
yeah,
education is amazing. There needs to
it
be more.
is. Hey, thank you. It's a lot of fun. We enjoy it. I think sometimes we forget because once you're in a menopause space, it's all you see. And so there are times that I think a lot of us in this space forget that there's still so many women that, like you said, they don't even know that they're going through this. They don't even know that it's perimenopause. We were never taught that. I had no idea what that was. They knew menopause was just when you stopped having periods and cycles, but there's just still so many women out there that just don't even know that what they're going through is related to their hormone fluctuations. So, I have to a lot of times take a step back and just remind myself that my world is midlife women's health and perimenopause and menopause. And that's a lot of just what I see. But, it is still a small, and we just have to keep, everyone in this space, they do such a great job, and they do so much work into on social media and whatnot, just trying to educate women so they know what's first to know that, hey, maybe this is going on, and then you go from there and try to find
Right.
someone that can help.
You're right, because there is a denial even out there, even if they
I
have the
think I denied
symptoms.
it for years. I would talk to a lot
Exactly.
of my friends about it, and we're just like, you're not old enough for that. What does that mean? And then you're told that you're not old enough. Oh, well, you're just in your late 30s, or you're just in your early 40s. You can't possibly be going through that. You're not old enough. And this is even by, older women you know, will disregard those. And so then, these women don't talk about it because then they're like, okay, I guess I am not old enough. And so it doesn't encourage them to talk about these things, and then so that's important too, is to not disregard these women if they are on the younger age, because you know what, we do have women that go into menopause early, early, and um, when their ovaries just stop working, right? So primary ovarian insufficiency is before the age of 40. So they may be having those symptoms.
Right. We didn't even talk about that. So that would be just so I can learn, that would be a woman who had like a hysterectomy younger. So they're automatically in menopause. Is that correct?
Well, only if their ovaries were surgically removed. So a
Okay.
primary ovarian insufficiency is a woman who goes through menopause before the age of 40, whether it is what we call iatrogenic, meaning that it just happens on its own, or idiopathic, where it happens on their own, or chemotherapy or surgery because their ovaries are removed anytime before the age of 40. So they're at an even higher risk, right, of osteoporosis and bone loss, of these musculoskeletal changes, of heart disease, of brain function, even more so than, women who go into menopause at the average age of 51. So, and then you have early menopause between the ages of 40 and 45. And then you have your regular menopause between the ages of 45 and 55, the average age of about 51.
So, well, thank you. You just added another conversation piece that I have to have with my female patients, and they're going to look at me even more squirrely eyed when I say, um, have you had any changes or surgeries in your life, even related to your female reproductive system?
Well, right. I
That's
mean,
important.
sometimes it might be worth asking them too, in that intake when you're talking with female patients, they may not think about hot flashes and night sweats. But I tell you, I've had patients, you know, pretty recently that came to me in their late 30s, mid to late 30s, that talked about hot flashes and night sweats. And sure enough, they were primary ovarian insufficiency. And we have to treat them not with menopausal hormones, but with hormone replacement. So they could actually replace what their natural bodies would levels that they would have until they are the average age of menopause. Or they can go down to menopausal hormone therapy if they discuss that with their menopause provider. They could do that in their late 40s, but we typically keep them on that until the average
Okay.
age of menopause. So
When I talk to them about this, their eyes get this big. And at first they look at me and they're like, well, you're a guy. What do you know about menopause and my stage in life? And then I'll tell them about you. And then I'll also say, and I know about the symptoms because I felt those hot flashes. I know they weren't mine, but I felt them under the covers. I would wake up and you would be an absolute furnace, and I'd be throwing the covers off and you're soaking wet. Like a few times I apologize to say this on our Zoom meeting, but I thought you wet the bed. You were soaking wet. And I'm like,
women do think that. They're like, did I just
it's
not
crazy.
wake myself up?
Yeah.
Yeah, I know. I know. I mean, I've been there before where I'm just like, what was that? And then, you realize that, thank goodness you didn't, but
So
whatever. Even,
just think about it. If it can do that to your body, just think what it can do
hmm,
to your joints, your knees, your shoulders,
right.
your elbows, and just think back to the things we talked about: shoulder, frozen shoulder, knees, arthritis, tendonitis, patellar tendonitis, um, ankles and feet, plantar fasciitis. How many women have come to me without an injury with these symptoms? Plantar fasciitis. I hear it every day. Oh, I was running, it got plantar fasciitis. But how long have you been running for? Oh, I've been running for like 30 years. But
Yep.
now you just have plantar fasciitis. What's the change? Did
Right.
you get a new pair of shoes? No. Did you have an injury? No. Did you change what you're running on or in? No. There's nothing changed in their life except, you know, their structures are changing. Their tendons and their ligaments are
Yeah.
getting weaker from this drop in estrogen, and their arches are falling. And that's why we have these symptoms. So it helps me so much
And that
to
that
address
throws
this stuff.
their whole body mechanics off then too, which is a whole nother
Everything.
discussion, right? Your arches fall, your feet widen, right? They splay out. And then, then their whole body mechanics are off because
Right.
they're walking differently. I would assume, right? Low back pain and knee pain then not just because of some of these other things that are already going on, but because now their body mechanics have changed.
Absolutely. And when Dr. Wright in this paper talks about the incidence of back pain in women in menopause and perimenopause state of their life because of the drop in estrogen, I mean, that is 75% of my practice is back pain. I need to sit back and reevaluate everything again. I used to think, was it the way you're sitting or driving or bending or lifting? It's always idiopathic, almost back pain. It's always idiopathic, meaning that there is no mechanism of injury. So this changes my profession significantly. So I'm just so happy to have, I feel bad that it took 20 years for me to figure this out and I had to be married to a menopause specialist, but I'm so happy
That's okay.
that
We all feel that way. All of us in this space are like
it's never too late.
apologizing to everybody because we had to like seek it all out. It just wasn't there. And so, but that's kind of a part of how fun it is right now is we're just a part of changing medicine, which is pretty dang cool, I think,
Very cool. And
so
it's like I said, it's never too late for anybody, for women with these symptoms to change them and seek out a menopause specialist like yourself, or to start strength training, or to change their nutrition, or to change and add the supplements. It's never too late. So if we can change by changing our practice and how we treat people, people can change to try to help themselves.
Yep. No, absolutely. I wanted to touch on at least one more thing because I was kind of interested myself and wondered if some of this went along with it. But, do you see a lot of these women too, where their flexibility is declined? Like they're just not, they're tight, they're not flexible, and maybe aside from those who are actively doing like Pilates and yoga and good stretching and things like that. But, these women tend to like ache. They get out of bed and they're aching. And, do you find that in this age group that they're just not limber, they're not as flexible, it's harder to get better movement in because of that?
Mm-hmm. It's actually twofold. The people who aren't active and don't exercise routinely, they don't know that they're inflexible until they try to bend over and pick something up or do something in their garden, and then they hurt themselves.
Yep.
And then it's the people who are active and run those 5Ks and do the resistance training. Those women in this stage of their life can't recover. They can't, you girls cannot recover. I've seen it. Like their muscles are just more sore after these workouts. They're tighter. They're stiffer. So that's when we have to do the education of all these. You have to have your nutrition. You have to have your strength training, your flexibility training. And one thing I think that neither of us hit on yet is your water intake. You have to be well hydrated. And then you have to see someone like you.
Yeah. And then, or get to some of these recovery places, right? I mean, I've done it before. The sauna, the cold plunge was really cool. Laser therapy, that definitely, my carpal tunnel was like completely taken care of. If I did an EMG, I probably would say it was moderate carpal tunnel, but I was like not interested in any type of surgery at all. So I did the laser. That was really helpful. I've done the laser. I posted that on like Scar Recovery. That was really neat, and decreasing adhesions as well with scars. So that was really cool. And then red light, I think is, there needs to be more studies and all of that, but I think what we've seen come out is pretty neat stuff too.
That stuff is invaluable. I'm really glad that you brought it up, the recovery services, because they're easier to get to now. They're more accessible. But I'm glad we could have a whole podcast on just recovery services. I think we should do that to let people know, like, what can you do that's really accessible? And don't forget just sunlight. You get vitamin D from sunlight, fresh air,
and it makes us all feel good, right? Sunlight makes us all feel good.
Grounding, get your feet on the ground. Cold showers that's your form of that ice bath. You can take cold showers. Get uncomfortable a little bit. Saunas, you get the heat shock proteins released with saunas. You get cold shock proteins released